So thank you to Maeva and Bruno for inviting me. I will try and keep my talk a little bit short because I know you're all probably hungry and ready for your lunch. So the main message of my talk is that some psychiatric drugs can be useful in some situations, but we fundamentally misunderstand what they do. And we need to understand psychiatric drugs better in order to use them more wisely. So we've heard about the difficulties of deprescribing. I'm going to talk to you about the issues involved in prescribing in the first place. As Maeva mentioned, there's a book, one of my books has been translated into French and it's due to come out soon, published by Fay Livre, I think. And they also incidentally publish some other interesting books on mental health. So the fundamental misconception about psychiatric drugs is this accepted view that what they are doing is correcting an underlying biological abnormality, that they are having what John Davis called a normalizing effect. This abnormality may be presented as a chemical imbalance, or it may be presented as some other sort of abnormality of neural circuitry or inflammation or other hypothesized biological mechanisms. And this view has been widely promoted by the pharmaceutical industry and by medical institutions over the years. And this view is what I have called in my work the disease-centered model of drug action. So it's a model that is borrowed from general medicine, and the idea is that the therapeutic effects of a drug arise from the actions of the drug on the biological mechanisms that produce the symptoms of the disorder or disease. And most drugs in general medicine work like this, even if they are only targeting symptom mechanisms, like, for example, your asthma treatment, you know, the Ventolin in your inhaler for asthma, or painkillers such as aspirin and paracetamol. But when we're talking about psychiatric drugs, there is another way that they could be having their effects. And this is what I have called the drug-centered model of drug action. And this is the idea that drugs are creating, rather than reversing some underlying abnormality, drugs are changing the normal state of the brain and therefore changing our mental states in some way. And these changes, these drug-induced changes, are superimposed onto people's underlying feelings and behaviors. And sometimes the drug-induced effects are experienced as preferable to what someone is going through. And an example of this way of understanding drugs is the effects of alcohol, which the changes that alcohol produces can lessen feelings of anxiety, particularly social anxiety, and also can temporarily remove feelings of distress and low mood like depression. This way of thinking about psychiatric drugs emphasizes that they are psychoactive substances. The changes that they produce may be pleasurable, as in the case of recreational drugs, but they may not be pleasurable. But the important thing is that they do produce noticeable changes in normal consciousness and awareness, in cognitive processes and emotion and behavior. And there are usually physical changes that are linked to these mental changes. For example, if we think of a state of sedation induced by a drug like a benzodiazepine, we can immediately understand that it has both physical and mental components. it's important to appreciate that there is a complex interaction between the drug and the body that evolves over time. So the effects of taking a drug for a long period may not necessarily be the same as the effects of taking one just for a short time. And this is why some drugs produce physical dependence and withdrawal symptoms because of the adaptations of the body. And some drugs produce persistent changes after they have been stopped. Now, people have used psychoactive substances to alleviate misery and suffering for a long time. This is a picture by Hogarth of the use of gin by the working class in London in the 18th century, and opium was also widely used at that time to medicate unwanted emotional states as well as to manage pain. In the 20th century, barbiturates and amphetamines and later benzodiazepines were used in this way, and they were understood at that time according to a drug-centered model. So they were understood according to the sorts of changes they produced. Barbiturates were recognized as producing sedative effects. It's an advertisement for barbiturates from the 1950s. Amphetamines were understood to produce stimulating effects. Drugs were also widely used in the asylums, in the old mental hospitals, but they also were widely regarded as chemical restraints. They were not seen as having disease-centered or disease-targeting properties. When the first, what we now call antipsychotic drugs, were introduced into psychiatry in Paris in the 1950s, they were also understood according to a drug-centered model. Chlorpromazine was the first one of these drugs. It was first used by two Parisian psychiatrists, Jean Delay and Pierre Dennecker. They thought it was a very useful drug, but they still thought that it was a special sort of sedative, and it was referred to as a major tranquilizer, also as a neurological inhibitor and as a neuroleptic, which means something similar. And you can see this understanding of these drugs from the way that they were advertised in their early days. This is an advertisement for one of these drugs, clearly emphasizing the tranquilizing properties. But over the course of the 1960s, thoughts about these ideas about what these drugs are doing start to change, and they come to be seen as working in a more specific or targeted manner. So textbooks of the time start to talk about how they do more than just tranquilize. And by the 1970s, they are being regarded as disease-centered treatments that target the biological basis of psychiatric symptoms, and they start to be referred to as antipsychotics. So here is an advertisement clearly highlighting this idea that they are targeted treatments. A similar process occurs with antidepressants. The first drugs that are suggested to be antidepressants have similar effects to stimulant drugs. Later antidepressants have different sorts of effects, but the early ones are similar to stimulants, and the early papers about them highlight their stimulant properties. But by the 1960s, people are starting to suggest that they are somehow different from stimulants and working specifically against depressive symptoms in a way that stimulants did not. So basically, how psychiatric drugs were understood to work changed over the course of the 1950s and 60s. And the disease-centered model was gradually adopted. And we can see this most clearly in the way that drugs were classified and named. So prior to the 1950s, drugs are classified according to the sorts of changes they produce. So they are referred to sedatives or stimulants, or according to other sorts of changes. But from the 1950s onwards, they come to be named and classified according to the sort of disease they are thought to treat. So we now talk about antipsychotics and antidepressants, etc. And this change does not come about because there is lots of evidence that these drugs are really having a targeted action. The majority of evidence we have about the effects of psychiatric drugs comes from placebo-controlled trials that do not distinguish whether a drug is having a disease-centered or a drug-centered action, because they're comparing the drug with an inert tablet. There is some evidence that might support the disease-centered model, and that would be if we had evidence that there were underlying brain abnormalities that were likely to be corrected by drugs. If we had evidence that certain drugs were superior to certain drugs that we thought to be specific treatments were superior to other drugs that we thought were not specific treatments, that would also be evidence to support, possible evidence to support the disease-centered action. But even if we had evidence of this sort, we would still need to exclude the impact of the psychoactive effects that the drugs are having. There is not evidence that there is not conclusive evidence, at least, that there are underlying biological, underlying pathologies that psychiatric drugs are targeting and correcting. The dopamine hypothesis of schizophrenia, for example, has not been supported by evidence, by strong evidence, and dopamine is actually not central to the action of all antipsychotics, although it's certainly a part, dopamine blockade is certainly a part of the action of some of them, and it was following the discovery of the dopamine blocking actions of haloperidol that the dopamine hypothesis was formulated, and it was formulated on the assumption that the drug must be working in this disease-centered way. There is also no good evidence that there is an underlying brain mechanism that explains the action of antidepressants. In particular, there is no consistent or compelling evidence that depression is associated with an abnormality of serotonin, as we showed in a paper we published in 2022. I'm going to skip these. So I've written more about the lack of evidence for the disease-centered model. If anyone's interested, I can send them references. But I want to now move on to what it would mean to take a drug-centered approach to the use of psychiatric drugs, to understand the drugs that we prescribe as psychoactive substances that change normal mental states. So that if you take this approach, the first thing you need to understand is what sort of changes is a particular drug producing. And unfortunately, because of the dominance of the disease-centered model, we actually do not have very good information of this sort. However, because antipsychotics such as chlorpromazine were discovered before that model really solidified, we do have some evidence about the effects of antipsychotics from animal and volunteer studies. And these show that antipsychotics reduce movement, attention, reaction times. Most aspects of learning are impaired by their use, and they reduce spontaneous activity. And subjectively, people report feelings of sedation, emotional flattening, reduced initiative, and reduced motivation. People who've taken antipsychotics for various forms of mental disorder echo these effects. They also describe feelings such as mental and physical stagnance, feeling emotionally empty, feeling lethargic and indifferent. And Pierre Denneker, one of the psychiatrists who introduced chlorpromazine, also believed that antipsychotics worked by producing a state of neurological suppression, and that the drug-induced emotional indifference that was a part of this state reduced the impact of psychotic symptoms. He commented that patients seemed to lose interest in their delusions, and actually other people at this time also made this comment, that people seemed to still have some delusional beliefs, but they were no longer preoccupied with them. This person describes the effects of antipsychotics very well, I think, so I'm just going to read out this quote to you. She said it's someone taking haloperidol for an acute psychotic episode. She said, "Although I felt very well, I felt as if I had absolutely nothing to talk about. I kept wondering whatever it was that had been so interesting during most of my life that I had suddenly lost. But I was very much in contact with reality, and for that I was thankful." So I think we can see that if we understand antipsychotics in that way, they may be helpful to suppress the symptoms of an acute psychotic episode. And this is what meta-analyses like this one show. However, we can also understand, however, it's important to remember that some people will recover from a psychotic episode without taking antipsychotics. In Manfred Bleuler's classic study, 22%, this is prior to the use of any antipsychotics, from patients in the 1950s, although it was published in 1974. In his study, 22% of people recovered completely and did not have another episode in the next 5 years. 58% of people recovered and then had a further relapse. So the majority of people, almost 80%, will recover from an acute psychotic episode. And other research has confirmed this, including a recent randomized control trial, placebo-controlled randomized control trial in Australia. But the benefits of long-term treatment, I think, seem less clear if we take this drug-centered approach, particularly for people who make a complete recovery or a temporary recovery. Now, what we know about long-term treatment with antipsychotics is that if you stop it, you are more likely to end up in hospital and end up having a relapse than if you continue to take it once you have started. Of course, that doesn't necessarily mean that starting it in the first place is a good thing, because some of that effect is likely to be due to with the adverse effects of withdrawal. And we know that withdrawal from some drugs, such as antipsychotics, can stimulate a relapse of the underlying disorder, as well as producing withdrawal symptoms, more general withdrawal symptoms such as agitation. This is an illustration of that withdrawal effect from a Dutch study that compared people who were undergoing a gradual reduction of antipsychotics with people who were on maintenance after a first episode of psychosis. And as you can see, if I can, probably can't even use that. Doesn't matter. As you can see, the people who had their antipsychotics discontinued were more likely to relapse earlier on. But as time went by, relapses evened out, and that's been shown in other studies as well. And this suggests there is something about the withdrawal process itself that brings on relapse. However, some evidence, particularly from this same study, suggests that long-term antipsychotic treatment impairs social functioning in the long term, at least in some people. So in this study, on this side, you can see that people who were randomized to reduction and discontinuation were more than twice as likely to show a full social recovery compared to people who were randomized to long-term continuous maintenance treatment. Now, we know that antipsychotics have lots of significant adverse effects, including tardive dyskinesia, which is a persistent effect, continues even after people have stopped taking the drug, although it often gets better slowly, and brain shrinkage, which has been shown in animal and human studies now. So we can conclude that, I think, that antipsychotics may be useful for the short-term treatment of psychosis, but long-term they may be necessary for some people, but for others, long-term treatment may do more harm than good. And unfortunately, we don't always know, or we don't know who will do well without treatment and who needs treatment. For that reason, several studies have been set up to try and see whether people can have their antipsychotics safely reduced and discontinued, including the MEPHISOS study in the Netherlands that I mentioned, also the RADAR study that I ran in the United Kingdom, and the DREAMS-FEN study that Fabrice Berner is running in France at the moment. I think he spoke to you yesterday. So what about antidepressants? I will just say a little bit about antidepressants before I stop. What sort of drugs are antidepressants? What sort of mental and physical alterations do they produce? The first thing to say is that they come from many different chemical classes, so they have a wide range of effects. Sexual dysfunction is probably the most consistently demonstrated effect that they have, change that they produce from normal functioning, and this particularly applies to SSRIs. They also seem to produce this effect of emotional blunting. One person described this as feeling distanced from life, and this has also been shown in volunteers, incidentally. And many of them produce lethargy and fatigue. However, they are not simple sedatives because they actually cause insomnia rather than promoting sleep in most cases. So then the next question is, are these effects likely to be useful in someone with depression or anxiety or any other condition? In depression, the differences between an antidepressant and a placebo are very small. They are 2 points overall on the 52-point Hamilton rating scale for depression. And no way that anyone has measured or tried to measure clinical significance makes that a meaningful difference. So, for example, this is a comparison between differences in the Hamilton score and ratings on the clinical global improvement scale, which shows that a rating of 3 or less does not even rate as any change. And you need to have a difference of 8 points to register as showing minimal improvement or minimal change. Moreover, this small difference is probably explained by amplified placebo effects because antidepressant trials are not usually completely double-blind, because many people can guess whether they're taking the real drug or taking the placebo, and we know that people's expectations of what they have been given strongly affect their results in randomized controlled trials, such as in this one. You can see that people who guessed they were taking fluoxetine did much better than people who guessed they were taking placebo, but it didn't matter whether people were, that was irrespective of what people were actually taking. And in fact, the people who did best were the people who were actually taking placebo but guessed that they were taking fluoxetine. So if that's the evidence, and that is the evidence, and there's no one is really disputing that, then why are we so commonly told that antidepressants work? A number of issues, a number of reasons. These unblinding issues are largely ignored. Data is often categorized, which inflates differences. Negative trials are not published or selectively published. And although it is often said that there is a subgroup of people who might do well with antidepressants, no subgroup has ever been identified, in fact. SSRIs and other modern drugs are not as toxic as older antidepressants, but they do have significant adverse effects. I'm sure you're aware of most of them, but I just want to draw your attention to these, what I have called legacy effects. These are effects that persist when you stop taking the drug. So this includes what are sometimes referred to as protracted or prolonged withdrawal symptoms, which can particularly occur if people stop their medication too quickly. And there is also a syndrome called post-SSRI sexual dysfunction, which actually occurs also with SNRIs and maybe with some other antidepressants, which is when sexual dysfunction occurs and persists after people have stopped taking their antidepressants. This is probably more common than we think. Some research suggests recently that 10% or thereabouts of people who stop antidepressants will have some persistent sexual dysfunction. So, are antidepressants useful then? What can we conclude? Well, the emotional numbing that they produce may reduce the intensity of emotions, but the lack of difference from placebo suggests that this is not actually a beneficial effect. And certainly not enough to compensate for the adverse effects that they produce. So I would suggest that instead we could treat depression in other ways using therapy or exercise, and if necessary, short-term sedative treatment for acute distress or insomnia. And in fact, NICE, the UK guidelines, recommend all these alternative treatments. They also recommend antidepressants, but they also say that these could be as good. So I've been trying to highlight how I think taking a drug-centered approach to the use of drug treatment is a good thing to do. It recognizes the uses, but also the limitations of drug treatment. It enables the useful effects of drugs to be matched to individuals' problems. It enables the individual to judge whether those effects, the effects of a drug, are useful or not for them. And it highlights the global effects of drugs, how they change the normal state of the brain and body, and the potentially harmful consequences of doing this. And this makes us more informed and should make us more cautious about using drug treatment in the first place, which would help to reduce all the need for the difficult deprescribing processes that you've been hearing about. And of course also suggests that we should be prioritizing other forms of treatment. So it's democratic, informed, and cautious, this drug-centered approach. And I just want to finish by saying this. The effects of psychiatric drugs are often assumed to represent evidence that psychiatric problems are caused by brain mechanisms, that are caused by brain pathology, brain diseases. If we recognize that drugs may have effects without rectifying without there being an underlying mechanism to rectify or without working in that way, then we can recognize, I think, that psychiatric problems are not necessarily in our brains. They are problems of people, not brains. And what I think that good psychiatric practice should consist of is helping people with the complicated problems that they face in life and not trying to tweak people's brains with interventions that we do not fully understand if we can possibly avoid them. Chemicals have consequences, as Dr. Adam Urato, who's a US gynecologist actually with an interest in the use of antidepressants in pregnancy, has said. Chemicals have consequences. We need to be very cautious about their use. Thank you.
Merci beaucoup. Alors, est-ce qu'il y a des questions ? Alors moi, je vais peut-être rebondir par rapport à ce qui s'est dit et après, pour conclure aussi la demi-journée. En fait, ça rejoint la première table ronde de ce matin et aussi la deuxième en termes de santé mentale publique, qui est de dire que les choses doivent se faire toujours en partenariat avec la personne dans sa globalité, en toujours pensant que la personne concernée est une personne qui fait partie d'un milieu avec des difficultés existentielles, des problèmes sociaux, et qu'on ne peut pas réduire une prise en charge, une prise en soin à la seule partie médicale, mais remettre tous les acteurs autour de la table pour justement, alors que ce soit à un niveau méta, c'est-à-dire à un niveau politique, ou à un niveau clinique de la consultation, prendre la personne dans sa globalité, pour pouvoir l'accompagner sur un chemin de rétablissement. Est-ce que tu veux rajouter quelque chose, Joanna? Non?
Well, just that I agree. I agree. Yes, that's a very good point.
Merci beaucoup. Et aussi vous dire qu'il y a plusieurs personnes dans cette salle qui sont concernées par ce projet. On avait déposé un projet de recherche national sur la déprescription avec le GCS. Donc il y a Déborah Seban qui est par là, Marielle Rouet. Enfin bon, il y a pas mal de personnes qui sont impliquées et on l'a obtenu. On vient d'avoir la bonne nouvelle. Donc c'est un PHRC national pour la réduction médicamenteuse. Voilà.